Hello, everyone. My name is Julie Lubisi. I am the chair of the Health Committee with the Omaha Refugee Task Force. We're here today to share and present on human trafficking perspectives in health with a panel of experts. And I want to introduce you to our co-sponsor, Karen Abrams. She's with Survivors Rising.
Hi, I'm Karen Abrams. I'm the executive director of Survivors Rising. We're an Omaha-based nonprofit that uplifts and amplifies the voices of survivors through education, engagement, and advocacy. And one of the important things we've done in the advocacy department over the last year is work with survivors in our network to provide testimony on two important pieces of legislation that passed in the Nebraska legislature in the last year. And those two bills are Legislative Bill 372 and Legislative Bill 497, one of which helps survivors to access services, and then the other 497 helps both survivors and healthcare providers get reimbursed for healthcare services that are provided. So we're very excited about that, and we're excited to be co-sponsoring the panel discussion here today. And with that, I'll turn it back over to the panelists to introduce all of yourselves. Thanks everybody for coming, and we're going to get started.
Perfect. Shireen Rajaram, and I'm a faculty in the College of Public Health at UNMC. And I do research and teaching, of course, and service, and very happy to be on this panel. Really appreciate it. Thank you. Sorry.
Okay, can I have Jen go next?
I'm Jen Tran. I am the forensic nurse examiner team leader at Methodist Hospital and Methodist Women's Hospital. Thanks for having me.
Thank you. And Kate?
Hello, my name is Kate Bueller. I lead the forensic team at Nebraska Medicine Main Campus in Bellevue.
Hey, and Dr. Kola?
Hi, my name is Betty, originally from Kenya, and I work at Boy and Family Services. We specialize in mental health and substance abuse, mostly with the refugee and immigrant population. On this side, I do research and presentations.
Thank you. And Tanya?
Hi, I'm Tanya Howard. I am with CHI. I'm a nurse care coordinator at the clinic, and we have the refugee contract, so we see a lot of the refugees here.
Thank you. Katie?
Good afternoon. I'm Katie Welsh. I'm the legal director at the Women's Center for Advancement. We are a nonprofit that holistically serves survivors of domestic sexual assault and human trafficking. Thanks for having me.
And Andrea?
Hi, my name is Andrea Poston. I'm a survivor leader in the community. I also run support groups for survivors, as well as I am a professional financial health coach, and I'm currently in school to be a mental health counselor.
Thank you everyone for joining us today. We did send out a bio of everyone because each of these folks bring a special expertise to our panel today. What I'd like to do though is start off with some ground rules and just an overview of how we will spend our time. In a moment, I'm going to talk about what safe space looks like for our presentation today. We're going to go through a formal presentation with each of our panelists, and then you will have an opportunity to ask them questions that you've been burning to ask. And we will end our time with a survey. And we hope you will share your thoughts and feelings as it relates to the information today and what we can do going forward as a community with refugees and human trafficking. Okay, so what is safe space? And typically I like to read this directly to you, so give me a second. Okay. Being trauma informed is an effort we try to practice in all our work, and we are continually growing in this effort. We acknowledge when we could have approached a person, situation, or topic differently. We honor this practice throughout today's presentation. This is a space conducted with mutual respect for all. Let's agree to not assume where anyone is in their life journey and interact with each other based on that understanding. Today, we have one of our survivor leaders present and will share their life experiences. During our Q&A, we welcome you to ask Andrea questions, but please know that they can decline to answer at any time. It is completely acceptable and respectable to go off camera or step away for fresh air if needed, as the content in today's presentation involves sensitive topics such as physical and sexual abuse and exploitation. If folks would like to stay after the presentation concludes to debrief with Karen and I, we will make ourselves available. Please send us a private message at any time during the presentation today. Now I'm going to hand it over to Dr. Rajaram to kick us off.
So I'm going to give you guys a brief overview on human trafficking from the perspective of public health. And folks who do clinical work as well, in many ways, take the public health perspective, sometimes without even knowing. Okay, it's not going forward. Human trafficking, it can be a public health issue, a human rights issue, criminal justice issue, child welfare issue. It could be international, national, and very much a local issue. And I want to share with you a few direct quotes from survivors who were part of a research project that we did a few years ago. And they're survivors right here in Nebraska, and I've changed their names. And so Shannon says, we always relate trafficking with like other countries, and we think about how terrible it is, you know, or workers or kid workers in another country. I removed the name of the country just because. But when we hear about how prominent it is in our own state, people are just shocked. It's just baffling to me that it can happen right in front of us and we have no clue. And so very much, as we all know, human trafficking happens here in Nebraska. And for the longest time, and still people ask me, really here in Nebraska, these things are happening. And I know with this group, we're very much aware that it's happening right here in Nebraska. And before we get into public health, I want to kind of focus us on just the whole spectrum of violence, because sometimes when we focus on human trafficking, we feel like that's like our main piece in there, and we forget some of the other violence that's happening. And so we put it within the context of intimate partner violence, or IPV, and sometimes they overlap, as you know. You could have somebody being trafficked, sex trafficked, or even labor trafficked by your spouse or by an intimate partner. And then we have the sexual assault and child abuse, elder abuse, and community violence. And so human trafficking oftentimes does not just happen in isolation. Okay, so very quickly, what is public health? Is the science and art, I do believe it's an art, of protecting and improving the health of people and their communities. And I'll try and break it down a little bit here. So one thing that public health does, we focus on the entire population, we focus on families, we focus on communities, and not just the individual, right? Something for us to keep in mind, both in terms of the root causes as to where trafficking comes from, but also how do we provide support to our trafficking survivors. And we also look at the cumulative effects of violence, for example. As we said, you have interpersonal violence and historical violence. And so that could be violence that has happened to your community over generations, like, for example, a Native American community, or in the case of the refugee community, you could have experienced violence in the past in your countries of origin or along your migration experience. And then you have the intergenerational violence that gets passed on from one generation to another. And then what we call structural violence, which is poverty, right? And lack of access to any kind of supportive resources within your social context. And so public health, we look at all these pieces, even if we are just focusing on the individual. Okay, and then we look at it too in terms of what's happening to you right from the time when you're born to when you die, kind of cradle to grave. And if I can look at all the way to the right, you have that conception to death, right? And we have a concept called adverse childhood experiences that many of you might have heard of, called ACEs. It's basically things that might, traumatic things that might have happened to you, either substance abuse in your home, intimate partner violence happening in your home, you've experienced neglect, you've experienced physical or sexual abuse as a child, and all these are cumulative. So if you look at the bottom piece on this triangle here. So you have your historical trauma, you have your social conditions, like we talked about, the poverty issues, the lack of access to resources. You have your ACE, so your adverse childhood experiences. And the concept here is that the more ACEs you have, the more negative experiences you have, the more it's going to hurt your health overall. Okay, and so the disease and disability and earlier death, but as far as human trafficking goes, it puts you at a higher risk. And I know Julie talked about this in her last presentation about the risks. Sorry about those dings here. And so that puts you at a higher risk for being trafficked. And it's not something that you personally did or did not do, but it's kind of the broader social environment. And also we look at the trauma, these adverse childhood experiences that you might experience, of course, as a child, they can affect your brain and your brain development because your brain is really in its infancy. And as we said, that can impact your health behavior, say alcohol, drugs, risky sex, increase your risk for poverty and stuff. And so we want to take into account this kind of big picture, small picture piece here when we talk about health and healthcare. And public health, very much we look at interagency collaboration. So even if it's the healthcare system, we talk about intersectoral collaboration. So you have medicine, right? Health and healthcare and medicine, but it's also intersecting with the educational system, with social services. Agencies like WCA, for example, provide amazing services. You have law enforcement, and then we need access to legal help in there, connections with your private sector, and also policy stuff. And we call this socio-ecological approach. It's kind of a geeky term, but essentially we're saying individuals live, are influenced by your family and your social networks, right? And then access to our social institutions. And we live in a community, and we have public policies that are impacting us. And so all these are connected in with human trafficking. As Karen talked about, they focus a lot on public policies in making sure that we change the laws that and to ensure that they support our survivors. And here's another look. And so we look at kind of the risk factors at the individual level, like we said, child abuse, homelessness, as Julie has touched upon in a previous presentation, LGBTQI folks are at an increased risk. And then maybe you have family conflict going on at that family level. Then maybe you have some social norms and peer pressure and maybe gang involvement at the community level. And maybe at the larger societal factors, people are just not aware and kind of clueless as to what trafficking is about, and it's so hidden to start with. And here's another example of the interagency collaboration when we provide long-term support for our survivors. So you have healthcare, but you also have social services and employment and law enforcement, legal services. Housing is huge. Behavioral health, as we'll hear about, is going to be huge. And then school-based professionals who play a key role in trafficking that our young people are exposed to. And then we talk about upstream factors, kind of the foundations of society, the building blocks of society, and what's going on there that puts people at more at risk for trafficking. But like I said, to prevent trafficking, how can we strengthen these building blocks of society? It could be education, it could be economic stability, your social context, your neighborhoods, and very much healthcare. And so this is kind of a broad perspective. And then oftentimes we focus on downstream. This is not a good example, but I wanted to pull one of my pictures that I took here over the summer in Utah. We focus here on the downstream factors, providing services, et cetera, to our survivors. And then one of the things in public health we talk about is why don't we go upstream and ask what's happening at the fundamental pieces of our society that's creating the risk and how we can strengthen it, as we talked about. Another piece public health provides is the levels of prevention. Very quickly, we talk about primary prevention to stop trafficking from happening in the first place, right? Provide upstream, so address the upstream factors, address the risk factors that are happening on day one, upstream factors. And then very much within the healthcare system, we do kind of secondary prevention where we try to screen people and have kind of early detection and provide them with support services so they can get back on their feet, and tertiary prevention to make sure that their harm is, continued harm is prevented. And increase awareness, and that's very much kind of an upstream focus to increase awareness. And I want to share with you what Becky, and again, these are not their real names, of course. She said, when we finally do break free and escape, it's not like you're breaking free. You're not escaping because you're still fighting. Now you're trying to fight to prove your point, because people are not aware, people are not understanding, and this happens within the healthcare system as well. One of the key barriers the research has shown in the healthcare system is the lack of knowledge, is the lack of understanding of people, and the stigma and discrimination that goes with it, and that creates a barrier within the healthcare system. So now Jane says a similar thing. That's a problem because nobody's really believing that is happening, even when your parents don't believe you, so you don't trust nobody else to believe you. Trust and confidentiality, another key factor based on the research of access to care, access to health care. And so we also focus on risk and protective factors. Sometimes we only focus on risk factors, right? But we also want to see what are the protective factors that keep people safe. And this is not a trafficking piece, but this is sexual violence. And so I wanted to put this in here. So stop SV as sexual violence. And so reaching out to our men and boys. And as we know, both females and males and other genders can be trafficked. So it's not just women. And then you create skills to prevent sexual violence from happening. And so these things are kind of applicable to human trafficking. Very, very much strengthen economic support for women and families, right? And create protective environments within schools, within workplace, within community level stuff. And here, the last one, support victims and survivors, is what we'll be talking quite a bit of how we're able to provide services to them. And so I'll skip this one. And so healthcare, so about 88% or more of people access healthcare services while they have been trafficked. That's based on research. And we believe it's more than 88%. And this data is from the hotline, and they show that the health services is the third reason how people are able to access care. This is the National Human Trafficking Hotline data. And so some of the challenges, and so there are many, many encounters that survivors have with the healthcare system that are, I'm sure, are very positive and go well. But I wanted to share with you some pieces that didn't go so well in the study that we did. So Becky said, I didn't want to go to the doctor ever again. Like for months after that, there was no sensitivity. There was no bedside manner for it. I felt like they were treating me as I was just some girl that came in and she had been drunk and, you know, someone just took advantage of her. And so she was very, very traumatized with the way she was treated at the healthcare system. And she really felt like we need to have a clinic for just trafficking survivors, period. And they do have those in different parts of the country, not here. And so she said when she went to the ER, they treated it more like as a rape victim. And these are two completely different things. And I think a lot of people don't get that. And so Alice talked about her experience with the psychiatrist. I went to many psychiatrists and I would tell them my story. Literally, they would sit on the edge of their seat like, what happened next? What would your parents say? You know, and I'm like, would you like some popcorn with this story? So, you know, that was a major clue to me that they were not going to be helpful for me. And so another example of how we need more awareness within our healthcare system. And Alice said, yeah, the emergency room needs to be knowing of ways to more discreetly give information. So she felt that that's an opportune moment where people within the healthcare system can provide information to survivors that they can use when they are ready, right? So the key thing is when they are ready. So she says, so when they get that moment, when they get that moment, they can call and they have that information. And I want to just close here with two quotes from survivors. So they basically say, look, they're forgetting this is a human. This is somebody who has been murdered inside already. I think when these things happen to you, you begin to shut down. It doesn't take long at all before you die inside. You're just a shell. It's really what you become. And Alice says, treat her like a human being. She hasn't been treated like a human being in a while. And so essentially these speak to what the research is showing is the stigma, the discrimination that they perceive, the lack of confidentiality, the lack of trust that people might experience when they receive services within the healthcare system. And so this is a study and it's available online. You can just Google my last name and UNMC. I'm sure it will come up. So thank you very much. I appreciate the opportunity.
Thank you so much, Dr. Rajram. Now we're going to hear from two folks in the health systems to share a secondary prevention effort called SANE. And I will share the screen for you, Jen and Kate. Let me bring it up for you.
Hello, my name is Kate Bueller. As I said earlier, I'm the forensic coordinator at Nebraska Medicine. I work pretty closely with Jen and her expertise over at Methodist, so I can have her introduce herself as well.
Hi, I'm Jen. I have been the coordinator for the past few years here at Methodist, and have been working as the role of a SANE since 2009. I'm excited to be here. I figure I'll tell you a little bit about our program, and then Kate's going to tell you about her program and the patients that we see for the community. But Methodist has had a program since 2003, and we respond to patients who present to the emergency department following sexual assault, domestic violence, strangulation, elder abuse, and human trafficking, if we can identify it. A couple big changes have come about recently, as we were talking about with the LB 497 and crime victims reparations, that will actually allow healthcare to bill crime victims reparations on behalf of the patient. So the patient doesn't, like currently the patient has to wait for reimbursement, which can be really difficult to pay a large hospital bill and then be reimbursed for it. So the changes would also allow the hospital to submit that rather than having to go through the patient or the survivor for payment. And then also, I don't think we've talked a lot or done a lot of publicity around sexual assault reporting, and that there are options now in the state of Nebraska, whereas prior we were mandatory reporters to law enforcement. And now for survivors who are 18 or older, as long as the deadly weapon was not used and there wasn't serious bodily injury, there's actually options to reporting. So I know Kate's probably going to talk about a lot of those options as well and how it pertains to survivors. So thanks for having me. I'm happy to answer any questions after our presentation.
All right, you can click to the next slide, Karen. I think, or so whoever's driving. All right, so briefly, Jen and I want to talk about like, what is a sexual assault nurse examiner? What is a forensic nurse? Simply put, a sexual assault nurse examiner or forensic nurse is a registered nurse who receives additional specialized training and eventually certification in forensic nursing. And what we are is we receive education on collecting an evidentiary exam, so completing that sexual assault kit that that you see on movies or TV, or maybe had some experience yourself. We receive highly specialized training to collect that kit. We partner with local advocacy programs on a regular basis, and we work with them to best support our patients and decrease barriers to accessing care. We also partner with law enforcement if a patient chooses to report their assault. We serve as experts to testify in litigation if that were to happen. And then last and foremost, what we view ourselves as an advocate in patient care. If a patient comes to see us after an acute traumatic assault, what's upfront in our mind is taking care of the patient and making sure their needs are met. And by needs, I mean both your medical needs, and then your basic needs. Do you have safe shelter? Do you have clothing? Do you have food? And can we help you acquire those things if you do not? I know both at Methodist and at our hospital, if a patient comes in after an acute assault, they will be cared for by a SANE nurse. And then if there's not a SANE available, we will work to get one. As Jen implied earlier, If a patient comes in after acute sexual assault, if there was not a deadly weapon used and they are over the age of 18, they do have an option to only see our care, and we do not have to report it to law enforcement. We feel very passionate about making sure people know that, because at the end of the day, we want to make sure anyone that needs care comes through our doors no matter what. And we don't want them to fear, talking to police or entering into a law enforcement system when maybe that's not what they want to do. They just need medical care. Next slide. So why do we feel a forensic nurse should be used, and what has it been shown to do by research? Research has supported that utilizing a forensic nurse maintains the chain of custody of your evidence. We adhere to proper sealing and labeling of that evidence. We collect DNA in the proper locations and the quantity needed. We collect the vaginal DNA swabs correctly. And then most importantly, we document in a manner that supports the patient. And last, we adhere to CDC best practice guidelines regarding patient treatment. So if a patient's concerned about STIs or HIV, we can help give medications that would prevent both of those things, and then give education about how to care for yourself afterwards. Anything you want to add to that, Jen, regarding forensic nursing care?
Nope, you're doing great.
Okay, next slide, Karen. So what is a forensic exam? It's simply put, it's a head-to-toe medical examination, and we place an emphasis on injury identification and documentation. That includes DNA specimen collection and then the preservation of evidence. We look at both biological and physical findings. We coordinate the care between the doctor in the room, law enforcement if they're involved. We always include an advocate in the care of our patients. And the forensic nurse is the hub of that care, and they ensure that the patient has all the correct people see them and talk to them throughout their visit. And at Nebraska Medicine, we are very fortunate to have several resources. So we'll include social work or pharmacy, infectious disease if needed. And the SANE nurse or the forensic nurse helps coordinate that care to ensure the patient has all the resources they need prior to leaving us. Next slide. So what does this look like in the hospital setting? This slide's a little confusing, and I almost changed it, but then it's apropos, because essentially no one's story is linear and no one's story is the same as the person before. We feel it's very important to give individualized care to every patient who comes through the emergency department. So when they enter into the emergency department triage, they're placed into a room. Every patient, regardless of why they come to the emergency department, is given a medical exam. And then at the time it's determined the patient needs a forensic nurse or sexual assault nurse examiner, we will have one arrive to the room. Here at Nebraska Medicine, we primarily work with the WCA. However, we can also work with Heartland Family Services if that's what best serves that patient. Our patients are given their medical treatment options, and then they're given their reporting options. And here in Nebraska, a patient can report a full report of a crime to law enforcement. They can have a partial report where only their name is included, or a completely anonymous report. The forensic nurse will walk each person through their options based on their specific scenario. If applicable, law enforcement will be notified, and then we'll interview the patient together as a team. After that time, we will complete our forensic collection. We'll provide STD prophylaxis and pregnancy prophylaxis. And if the patient's medically stable, they will be discharged to a safe location. If they're not medically stable, they will be admitted to our hospital. Or if perhaps we're having some barriers to a safe disposition, they're either they stay in the emergency department or they're admitted to the hospital until we can find a safe disposition for the patient. Next slide. We also think it was important to mention to you the sexual assault response team in Douglas County. Specifically, that is the team that Jen and I sit on. This is a survivor-centered team that is comprised of multidisciplinary folks that are really looking to wrap their arms around our survivors and decrease barriers to access of care, to reporting, and and others are focused on preventing assaults altogether. And so we have the survivor here in the middle. This team has forensic nurses, community advocates, law enforcement agencies, the prosecuting attorney for Douglas County, shelter advocates, and university and college representatives. Next slide. For refugee-specific considerations, we use translation services. At Methodist Hospital, they use the Marty video system. At Nebraska Medicine, we use, it's called CLI, Interpretive Services. We do have in-house Spanish interpreters, and we have sign language interpreters if needed. But we always ensure that a patient has access to interpretive services prior to us performing our exam. We have legal aid that is available to all of our patients. And then of course the Immigrant Legal Center. And then with the funding for the care that they receive at our hospital, there's two funding sources. One is the Sexual Assault Payment Program, and one is the Crime Victim Reparations Fund. And both those are aimed at decreasing your medical costs associated with an assault. Next slide. And this is just a short reference slide, and I welcome, and Jen welcomes any questions, please.
One thing that I was just thinking of is we have the Methodist Community Health Center at 26 in Douglas that's housed with the Kuntz Commons. And that clinic really focuses on underinsured or those with no health insurance. And so it might be a good resource for those working with refugees or people who don't have insurance to be able to seek primary care in a cost-effective way as well. So just something else to keep in your back pocket.
Thank you both for your time today and presenting on the SANE program. That's very informative. Folks, you will have opportunities to ask them questions directly in a moment. We have some questions for the rest of our panelists. And our first question for folks, Dr. Betty Cola from Buoyant Family Services and Tanya Howard from Common Spirit, formerly known as CHI. This question is for both of you. From your perspective, what are the risk factors that leave refugees vulnerable to human trafficking?
But I will start with the migration flows. And some of those flows include children being unaccompanied during that process. And that's one of the major risk factors. We also have limited access. So once refugees get to the host country, we have limited access to education or even quality of education, given the language barriers that most refugees face. Another one is compromised barriers to the education system. Most of these refugees come from different educational systems. I'm an immigrant and I was raised within the British system of education. So that's completely different from America. So and I'm going to explain later, but I just needed to point that out. Then we also have the compromised mental health, which is often overlooked. And I have a solution for that, at least partly. And then the separation from families during that transition is a major risk factor as well. Then we also have shifting family dynamics, especially once they get to the host country where the culture is different. They live in overcrowded houses. Again, back to language barriers, and especially now between parents and kids, where kids get to speak English and parents don't. And so that's one of them. And then transportation barriers. They have to depend on whoever can get them to where they're going. So that's a major risk factor. We also have isolation in the host country, which with this isolation, then they're left to get into the wrong company as a coping mechanism, like drugs and gang affiliations, so that's one of the risk factors. Yeah, I'm going to stop there for now. So Tanya.
No, I agree with a lot what you said. Language barrier is huge, and getting connected with services is huge. Sometimes they'll come for the 3 appointments that the refugee contract pays for, and we don't see them after that. So they don't understand that they can come and seek care, or and they're victimized a lot for the lack of knowledge of how America works, what's going on. Poverty is huge, multiple things.
From your experience, how has human trafficking impacted your clients or patients?
From a lot of the clients I've seen, there's the need for economic survival. Life has become so expensive. And so when refugees get to the host country and they can't get around, they don't speak the language, they don't know the rules, it becomes a matter of survival, economic survival. And so they become openly vulnerable to traffickers who know how to identify them. So I found that to be a major one. There's also one thing most refugees don't like to talk about unless you get to really work with them closely. There's a high percentage of sexual violence within the refugee community, and half of that goes unspoken. They don't talk about it. And I've seen that, yes. There's the gender discrimination. And so when women and girls are forced to survive with the only person they know, I've seen that also. Another impact of this is due to the sexual violence. I've seen an increased percentage of women and young girls getting sexually transmitted diseases and HIV mostly. So yeah, that's from my part.
I would just say, I know in healthcare, I know with a lot of our physicians, sometimes it's not on the forefront of when they're doing these examinations, we have patients that have all these random symptoms, and we miss a lot. And so they keep coming in, and we're missing that piece of it. They'll run a million tests, but not think about maybe there's something else that we need to be talking about and checking in with. So I feel like a lot of the healthcare systems, it's not at the forefront of their health assessment.
So building on what you're saying, Tanya, how can the healthcare system improve its services to help refugees experiencing exploitation?
That's a tough one. I'm not exactly, education, absolutely. Education and educating the physicians is huge.
Like Tanya has said, education is huge, but we need to tailor educational programs to, I could be biased on this one, but we need to tailor educational programs to actually include psychosocial support for these families. Another area is we need to have programs that enhance language skills, not just for children, but for parents as well. We see a huge gap where parents only know the one language they know, but then these children get to speak English. Now we have a language barrier within the family itself. So how difficult is it when they go out there? We need to take preventative measures, such as, this is one idea I've always thought of, and if I was a policymaker, I would actually have like a family navigation program, to where when a refugee family, we know they're coming, we need to have like a team that's going to work with this family, where they're going for healthcare. They do have these college interns that can be paired with these families, social workers that can be paired with these families to help them navigate the system, at least for the first 8 months or something. Otherwise, these families are confused, they're frustrated, they don't know where to go. And I get to see those clients when CPS comes in, or when their rights are terminated and they just don't know why. So, and then we just need to have an improved legal protection system, because refugees are of the opinion that They don't want to deal with authority, but we can't blame them because in their countries, including mine, we don't confront the police. We don't tell the police nothing. We don't. And so I think having those programs to just have improved legal and protection systems for refugees. We need to have improved relief and social assistance programs for refugees. One shoe does not fit all. Just because you're an American or you're an educated immigrant or aware doesn't mean that a refugee is aware of those services or even how the system works. So how can we break it down and tailor it to refugee to serve the refugee population, you know? And then we need to have more information sharing, kind of like what we're doing right now. But the last one I'll stress is collaboration, collaboration, collaboration. We can't do it by ourselves, no matter how much money you have. And I'm going to say that. For example, your organization, they might get grants, yes, but some of us work with these folks right down to their personal lives, things that they will tell us that they will not tell you, the person who gets the grant, you know. So, or even them going to the clinic, they tell the doctor one thing, they come and tell this person the other. So collaboration is one of the biggest keys.
Oh, thank you, Dr. Kola. That's great input. Does anyone else have anything to add before we move on?
This is Martha, and I appreciate so much Doctor's perspective on this. I also think that our refugee population is targeted the minute that they get into town by the meth dealers, by many of the trafficking. And if we can even start within our educational system at the universities for all of our students who are dealing with healthcare services, to have these collaborations, these simulations, where in the mix of that simulation, everyone has, a tattooed gum or something in their history that they need to pick up, and to say that it would not be complete healthcare if these people weren't identified early, screening frequently, every visit, every time, every woman, man, and child that comes in, looking into people's eyes. It cannot just be a flow chart. It has to be that feeling that those eyes can tell you there is trauma. It's the ACEs, like Shireen said, but also just every refugee that steps on our shores is going to be, are going to empower our country, but they also are ones who are going to need us to hook arms with them until they get up to speed.
Thank you, Martha, for your input. Yes.
Can I share a little bit?
Sure, Yogendra, please. Nice to hear you today. Thank you for joining us.
Thank you. Yeah, we have a dealing right now a lot of this issue, especially most of the five issue I already deal. Sometimes a lot of the here American style when we violence. Sometimes when they come, we referral immediately. Something is legal issue. Sometimes the client also blame us because of this. He's that I don't want to send to him jail. And right now we have also last week we got a last 1 month when the client come. Beginning of the time she want to go and legal issue, we provided that you have to go legal issue this days is provide, and what you want, you have this option, and we provided with the referral immediately women and advanced center. Then I think she have a meeting with advocate, and finally she has a brother, she has a family issues going on, but finally, and she decided, and she don't want to go in a legal issue because of her immediate family member. So a lot of the issue coming sometime first, what is the, because of his brother, he's not educated to the this system. Some African culture, there's somebody coming that issue, something is happening, he has beaten, and she has all the time checking his sister all the messes, all the things, and something is happened that one day night and come that is to happen all the time happen. But first, we also provide that this issue. First, we educated still, refugee family. This is the America. We need to provide the education and empower to them and find their solution them. That is the most important things, because of a lot of the case misinterpret, and some case, when something they don't know, they call 911, something call and they go there, and they after the 1 week, they crying, they want to their husband themselves, then they are, drug, what is called substance misuse. That's a lot of things is going on, but we need to be aware the client educated is the most, education is the most important working with the family.
Thank you for your input, Yugandra, and that example. I'd like to have a question for you, Katie. What programs and services does WCA and other community-based organizations provide victims and survivors to address their health and well-being?
Yeah, thanks for that question. I am the legal director at the Women's Center for Advancement, and I think what we try to do is offer holistic wraparound services for survivors. So right when a survivor comes through our doors or calls us on our hotline, what our greatest priority is addressing their immediate safety needs. We're trying to figure out, we're trying to assess what the danger is to them, and that's what's bringing them through our doors. We're helping them safety plan around their situation, and then we're assessing what kind of emergency is affecting them and their needs. So do they need emergency housing and shelter? Do they need food? Do they need clothing? And how can we get them connected with an advocate? But it's really important that as we're starting this process, that all of this is survivor-led. So the more involvement that we have from the survivor to decide, what makes sense for me and my circumstances, that's most important. Once we, through our services, address the emergency needs, then eventually we move into kind of addressing short-term and then long-term needs. So we work with a lot of our trafficking clients on transitional housing into permanent housing. We work on legal assistance. So if they were forced to commit a crime while they were being trafficked, perhaps it's something we could help them set aside in a court, or perhaps they gave birth to a child as a result of their trafficking situation and are seeking custody. We also have an immigration team here as well. So we're helping clients who don't have status in the United States to apply either for U visa or T visa, or in some cases to self-petition under VAWA. We're helping clients retrieve ID documents, helping them set up and attend appointments, pursue employment, participate in health screenings, and then we have access to resources in the community where clients can find financial assistance. I know a lot of times there are prescriptions that are really prohibitively expensive, and in order to maintain or bolster a survivor's health, we need to help them pay for that prescription, or even figure out what kind of prescription they need. So we try to connect them with resources in the community to allow them to do that. Those are just a few of the things that we try to help survivors with. But again, it's survivor-led and it's specific to their circumstances. So not all of these are necessarily always appropriate in every situation. Many of them are. We primarily, like I said, help with legal needs that are civil and immigration focused, but we have helped clients in criminal matters in limited circumstances. So we try to be as flexible as we can within the model, the holistic wraparound model that we have here at the WCA.
Thank you. Thank you so much, Katie. I want to bring it back to the healthcare system as folks are here today to learn more about that. But we realize that survivors are working with a variety of systems, right? And so having the input that Katie brings to the table is of great value, because while folks are going to the healthcare system, they're dealing obviously with legal issues. So there is great support as well as connections between the various providers. And I think we saw that in some of the presentation before. We'd like to ask you, Andrea, how did the healthcare system help you address your health issues?
Really, I can't answer that in a way like you asked, because I have more ways than that they've not helped me, if that makes sense.
No, it does. And thank you so much for saying that. So would you like to share some of those examples and experiences that you had?
Sure. So back when I was working as an escort, I was getting off late one night, and I went to go get gas at a gas station. It was very dark. There was nobody else there but me. There was another car there, but I didn't think anything of it. Anyway, long story short, I was pulled, as I was pumping my gas, I was pulled into a car by two men, and they held me down, each took turns and raped me. I was close to Lakeside at that time, so I was bloody. I had their stuff all over me, and my clothes were ripped. I drove myself to Lakeside in that state. I walked into the emergency room, and I'm not going to say names, even though I remember names, but the staff at Lakeside informed me, we don't do rape kits here. You need to drive yourself to another hospital. They didn't try to transport me. They didn't try to comfort me. And then I asked them, where should I go? What's close? They said, the only hospital that can help you is Creighton. You need to go down to 30th. So I was all the way on 160 something and had to drive all the way down to 30th in that state and in the state of mind that I was in. When I got to 30th at Creighton, I went in there. I was treated like I was a druggie looking for drugs, like I was a drunk. I wasn't treated with respect. I tried to say what happened. The nurse asked me a few questions. Then she left me alone for a very long time. The next person that entered the room was a male law enforcement officer. He was not accompanied by a female at all. Then I was informed by law enforcement, without an advocate there, without a nurse there, without a doctor there, that is not rape. That is theft of services because of the trade I worked in. It was never investigated. So that's one of my major experiences. And I don't come from a place of bitterness. I want to empower people. I want people to grow. I was never once asked if I even feel safe. I was never once asked if I was being trafficked. I was never accompanied by an advocate. And that's just one of many stories that I have with the healthcare system. And I don't mean to call out CHI, because CHI is not the only healthcare system I've used, but I feel like the ball has been dropped.
Really greatly appreciate the time that you've shared your story today. I'm wondering, from your perspective, how might the healthcare system improve from your experience, right? Folks who, so that this doesn't happen again with folks who are experiencing exploitation.
Absolutely. So I feel like, first and foremost, when a person comes in that state or any state and says they've been sexually assaulted, whether you can help them or not, you should immediately do your best to help them, provide them an advocate. If I could go back and say that things that could have been done differently, I would say I should have been transported to another hospital if they couldn't help me. An advocate should have been provided to me, somebody, a nurse. I wouldn't have cared who it was, just somebody to stay with me, because the state of mind that I was in, I wanted to run myself off of the highway, driving myself all the way to another hospital. My emergency contact was not even contacted. I had to call my emergency contact the next morning and tell them what happened. I think when it comes to trafficking survivors, most of all, especially children, they should always be separated from their parents. I don't care how the parents feel. I don't care if they don't like it. They should never be asked if they feel safe in front of the person that brought them. They should always, even if, you know, you make up something like, oh, I'm going to go to the bathroom with you. You need to stay right here. I'm going to go to the bathroom with you. They need to be asked those questions separately. What else? Also, I agree with the part about having funding for victims and survivors, but my question, can I ask a question? With the funding, is it anonymous? Does the person have to give up their information in order to get that funding? Because it's shameful to us. It's embarrassing to us that we even have to tell our story a million times. We should only have to tell it once, but we have to tell it a million times to everybody that comes into that room. And then should we have to give our name? Should we have to give identifying information in order to get that bill paid for? Because 9 times out of 10, most trafficking survivors or victims at the time don't even know they're being trafficked when they're being trafficked. So they're not going to say they're being trafficked. So should they have to identify with that in order to get the funding is my question.
Thank you for the question. Is anyone on the panel able to respond to that particular question?
Thank you for that question and your honest assessment of what happens in Omaha and likely every city across the United States. To get some of your bill paid for, no, you do not need to talk to law enforcement. You can do an anonymous kit. Like if a person was sexually assaulted and they reported to either Jen or my team, we could enter into an anonymous kit or give you medical care and seek some reimbursement for the state without your name attached. Okay. But crime victim reparations funding by the state statute does require a person to be engaged with law enforcement. We are very limited by how the bill and the law is written to provide support with that way to you. And I agree with you. It's not ideal for people at all. And it's a barrier, and it makes some people not seek care. And that's something that every single person on this call would be vested in writing their legislator about. Jen, do you want to add to that?
Yeah, I was just going to try to peruse the new language. I know prior you had to have reported within 3 days, but I know that was removed, but I'm not sure what exactly it was changed to. So I don't want to say something that's not true, but they did take some of that out to give more time. I'm wondering though, since with the change, we can bill crime victims reparations as a healthcare facility if our diagnosis code is sexual assault. It's not necessarily looking at whether or not you reported to law enforcement, but I could be wrong. So I want to look a little bit more into that, and I can come back to the group with the answer to that. They also took out where it used to have to be notarized to apply for crime victims reparations. That went out. So the bill actually goes into effect 90 days at the end of the legislature. We're still waiting for guidance from the state on exactly what that looks like for hospitals to submit that bill. But I'm hoping I believe they were pretty trauma-informed when they were going through the edits to crime victims reparations, acknowledging now that we have this anonymous reporting option, how can we best suit, what's best for the victim? Because you couldn't report anonymously and be eligible for crime victims reparations because you had to report to law enforcement within 3 days. So since that law changed, I think they recognized that the crime victims reparations had to change in conjunction with that. So let me do a little bit more digging just to see what exactly that will look like, and I can get back to you guys shortly.
Thank you, Andrea, for sharing. Now, if somebody goes to Lakeside and they are not equipped to do a rape kit there, what is your appropriate protocol? Because I mean, to have somebody drive all the way to another healthcare system just seems so horrible. Now, I mean, I would think our huge healthcare systems, say Nebraska Medicine or CHI, are able to deal with it better. Can you guys provide some insight?
I can speak a little to our practice at Nebraska Medicine because until recently, we did not have 24-hour coverage at our institution. Fortunately, that changed in December of 2020. With that being said, we did utilize Methodist services and we worked closely with Jen's team over there. And so how it would look here, by federal guidelines, EMTALA laws, we have to give every patient a medical screening who enters our doors. So when the patient comes in the emergency department with a chief complaint of sexual assault, if we did not have a forensic nurse on, they would get a medical exam by a physician, and then we would have a doctor-to-doctor handoff with Methodist at that time. We would give the patient a choice. If they had a support system with them and they wanted to go by private vehicle, they could do that. If they didn't feel safe and they wanted to go into law enforcement, they could do that. If they needed ambulance transportation for some reason or another, we could facilitate that. Again, with any other forensic case we would complete, it's individualized based on that person's specific needs. So that, I guess that doesn't answer, it's not cut and dry, every patient the same. What I can say is we individually assess the situation and work with them in their comfort level of getting to Methodist at that time, if you will.
Thank you.
Andrea, and I don't know if those options were given to you, or I would love to know if anyone else has any other input or options they think would be more trauma-informed and patient-centered.
Jen, it'd be great to hear it. And then Tanya, after you shared Jen, Tanya, would you like to add to that?
I just know now that they have the same SART that will go to all the hospitals. So I don't know exactly how that process works with each facility, but I do know they even come to our clinic when we have things happen here that we need to have them come and do the examination.
Yeah, as an advocate, probably about a decade and a half ago, I remember that at one time it was only Methodist in our community that had the same program. And it's for me in this process of setting up this panel, I got to see the growth of the same program. And so what's I think great about having this panel is to kind of demonstrate where we still have the gaps in our service system and where we need to go. And so this is a great opportunity to do that. And I think Jen, you had something to share with regard to the situation before we go on.
I was just going to say that we see that across the state too, where the victim comes into another healthcare facility because of EMTALA, they're required to transfer if they don't have the services available. And so they'll do a transfer to one of the facilities that does have a same program. And I think it also speaks a lot to the care that we weren't providing in the past, and that, you know, our Methodist numbers when we were the only program are pretty impressive, but now, you know, other programs exist within the city like Nebraska Medicine and CHI, and their numbers are really impressive. So how many times did patients come to the emergency room and were told, oh, now you got to go somewhere else? And that was their cry for help, and we failed them. And so I'm glad that no matter where you go, there's no wrong door now, that you can get sane care. But granted, we're not perfect. And I know that we have growth and learning to do, and being able to have dialogues like this where it's safe to ask questions and get answers is exactly what we need to be better.
Thank you to everyone.
Can I say something, Judy?
We're going to open up questions in just a second, folks, since our time is going. So 1 second, thank you. We have, before I do that, we do have a question in the chat. It's for the folks in the SANE program. Are victims allowed to bring a friend with them during the physical exam as emotional support or for interpretation?
Yes, we do allow visitors in our emergency department again.
Okay, thank you, everyone. Lots of information being shared and thrown at you. Jean-Claude, you had a question? Would you like to start off? Thank you.
Yes, I have a question and perhaps add something. I've been working most of the time with refugee families, and I want to just thank you, first of all, for this panel, how people can learn and then discuss about especially survivors. And then I also want to thank Dr. Betty Kohler for what she says. It's very, very important. Something that I want to say is that the survivor of sexual or trafficking, sometimes it's hard for I'm going to talk about the especially refugees. Most of the subjects are kind of taboo, something to say or to discuss. And in Nebraska, I saw that there is a gap in the community health. And then I want to know today and ask a question, what is the health system do or improve to help especially those community who normally have problem to communicate, especially with the barrier language, because some of the families, some of folks can't even come to hospital to talk about those problems because they fear even to come to the hospital because they can't speak, perhaps there's no one to help them. And then I think for me is the health system to find another way to reach more the community, especially through the community health. Is it a way or something that they can do, especially to train or to help, especially people in the community, because of the one who will be more trusted and then to talk on behalf of those communities. So what's exactly they do or they can do to help, especially to reach more people in the community? Thank you.
Thank you for the question. Any of the panelists, feel free to jump in and provide your input. Please go ahead.
If I might attempt responding to that, am I hearing that we might need more community health workers?
Yes.
People from the community who are connected closely with people in the community, maybe who speak the language, who know the culture, who live in the community, as to be that first connector to people in the community, and then they get to be the liaison with the larger healthcare system. Because again, the same thing the research has shown, that it's just too intimidating for people to reach out to the healthcare system. I mean, all of us who are, so-called educated and know the healthcare system, it's still a big maze and it's really difficult and challenging, and you don't know where to go, and this clinic and that clinic and stuff. And even more so if you're a refugee, even more if you've experienced sexual assault, even more so if you are a human trafficking survivor, right? And so maybe the first layer we should build is that community health network in there where people are closely in touch with that community health worker, and then they can help them navigate the larger system. I mean, we've done that in many different communities, and I don't know, that's something that might make sense here. Just putting
Yes,
that.
I think, yeah, that's the point normally. That's what I'm talking is. I think there is a gap between the health system and the community, a big gap. Because there's no communication, no education. So I think that's what they need normally.
I agree. And I think we need to meet patients where they're at. And a lot of our gaps, and we don't have a same program at One World or any of the community agencies that work with, and especially with the climate that it is, people aren't going to want to report to law enforcement because they don't know what that means. And so if we can get through those barriers and meet them where they're at and have programs where they're at, I think that will be really beneficial as well for the future work.
There needs to be that trust connection at the grassroots level with people in the community that is oftentimes just totally missing. I mean, that whole infrastructure at the grassroots level is completely, totally missing from a public health perspective.
I see Martha's hand up. We're going to go to you, Martha, and then I'll check the chat for other questions.
So it's really important when you're talking about those community health workers to make sure that they are well paid, because their responsibility then becomes as a counselor, as an advocate, as a transporter, all of these different roles, because they are then that central person for the bridge between community and healthcare system. My heart just broke for our panelists who shared. I really appreciate that. And I am an old enough healthcare provider that I know that in the rural areas, even though we didn't have a sane provider there, we would not have let that person go without having somebody with her. I mean, it's a high risk situation. It would be like, it's a trauma. It's an assault, it's a physical and sexual assault. And it breaks my heart that we have gotten so much into a system that we just think that a sane provider at one institution or two institutions is going to be taking care of the 1 in 4 sexual assaults that is going to be happening and probably increased in these next years. So I would hope that we are thinking rural and community health centers and rural and small hospitals, that there is an ECHO response, like is set up around so many of the rural states, that there are experts trained and available in all of those situations. And I understand call. I understand being on call. So it's something that we might want to really discuss, of how to have in our refugee community also those who are native language speakers from the global South and able to respond. Thank you.
Andrea?
Yes, I'd also like to point out, to kind of further that not only did that happen, but later on, after I got my bearings, I reported it to CHI, and a few of my doctors dropped me because I complained. They were informed that it was a conflict of interest to continue to see me because I was a complaining person. So it broke my heart, because some of those doctors, I was very like, the rapport was there. It's hard as a survivor to even build rapport with people, and the rapport was there. I thought they cared, and I was dropped very quickly, like within my next visit, because I complained.
Yeah, I'm sorry, Andrea, and thank you so much for bringing some of these issues to light. So I want to use exactly what you said to ask everybody a question. Now, Andrea speaks English very well, and all of us can understand what she's saying. So imagine working with a refugee client who does not speak English, has gone through this, and is being treated the same way. And that's one of the major reasons why most refugees do not even come up and speak.
Yeah, thank you both for your comments and amplifying that issue, right? We know that reporting is very difficult in the first place. So our time is about 5 to 7 minutes. I'd like to open it up for more questions. I do see some comments within the chat. You're more than welcome to unmute and share those verbally. But I do see you, Nabras. Go ahead and you have a question.
Yeah, in addition to what Betty said, like, imagine if Andrea, she knows English, she's from this community, she knows her way around, and she's brave enough to report. But imagine if it was a refugee who does not maybe even have the support of her community, because there's a lot of victim blaming and shaming. What was she wearing? What was she doing outside at this time? So I would imagine they would not go and report such incidents. So like Jean-Claude said, there needs to be more education, and if we all work together on getting information to educate families.
Thank you so much, Nabras, for your comments. I really appreciate everyone sharing and giving your expertise today. This is a very difficult conversation. It's never easy to be had, especially when it comes to systems change. Our goal, if you have not noticed, is to be survivor-centered, survivor-led. Again, another new effort in the Omaha area. So I'll stop and see, is there any last words?
Okay, I'll go before Karen wraps the whole thing up. I was just, maybe in the health committee, people can look at, and this is to people who work within the healthcare system, of how to address that stigma and discrimination that people from the outside experience when they interact with the healthcare system. So maybe folks who are within the system might have some ideas of how to address that stigma and discrimination that you can sense that your colleagues have, right? I mean, so I'm asking as insiders, your perception, and I know we're kind of out of time here, but that's something that always intrigues me, because otherwise you have these interventions coming from outside, but people within the system know it, they see their colleagues having it, right? And maybe they have some thoughts on how to address the stigma and discrimination against refugees, against women who've experienced sexual assault, you know, I mean, kind of all of the above. But thank you.
Okay, good. I just wanted to thank everybody for coming. This event itself is a partnership between Survivors Rising and the Omaha Refugee Task Force, so it's very exciting. This is the first time that we've had an opportunity to join forces. From Survivors Rising's perspective, we always think it's essential to include the survivor voice in all of the work that we're doing on issues that intersect with survivorship. So we're so excited, Andrea, that you were able to join us. Thank you. I want to thank everybody for joining us. And with that, I'll hand it off to Julie for the last goodbye.
Thank you, everyone, for joining us today. The Health Committee, we will be meeting again next month, and we can continue this dialogue. For those of you who are interested in joining the Health Committee and/or task force, please reach out to me and we can get you connected. We'd love to have you on board. I'm going to put my email in the chat. You can connect with me there. And any of the panelists, if you have any resources that you'd like to share with the Health Committee or folks who've registered for the event, feel free to share them with us. We'll get those out. Thank you again, everyone. Enjoy your days.